Hello, my name is Quincy Schneider, and this is my final case presentation. To begin, three questions to further discussion is one, how can parents balance validation of emotions with setting firm behavioral limits? Two, what interventions are most effective for managing intense emotional dysregulation in young children? Question number three, what additional assessment tools or strategies would you use to better understand the triggers and patterns of these episodes? The case overview. My client is a 4-year-old female. She lives with both her parents who are married. She is an only child within the home, but does have two older half brothers on her father's side, both whom live out of state and the whole family has no contact with. She attends daycare and participates in a gym based childcare while parents exercise. They recently relocated from Colorado to Florida. Some of the presenting problems parents reported frequent intense emotions and behavioral dysregulation. These behaviors include hitting, biting, kicking, scratching, screaming, and running away. These episodes occur about 4 times a week, lasting from 1 hour to an hour and a half. And this happened for a better part over a year. Some weeks were less, some weeks were right at the 4 times a week mark. It did change bi weekly, but overall, it did consist over a year. Primarily, this was directed towards the mother, and it escalated when the mother would try to re-engage, which looked at the dad would take control of my client, maybe bring her to another room. She would scream and cry for her mom. The mom would re-enter the room, and then it would just re-escalate. Also, this is also observed in daycare setting as well, just not as frequently. It was more frequently within the home. So, some relevant history. The onset began in the previous daycare in Colorado following the departure of a teacher. The exposure to biting behavior was from a peer at this specific daycare. There's also been increased behavioral concerns following relocation and transition to the new daycare in Florida. The reduction in external extracurricular activities in Florida, and developmentally, she is on track and is described as a highly social and active child. The referral source and reason for services. So the parents were self referred to 40 Carriage Children and Family Center. Their familiarity with the agency was through a hospital affiliation. And they're seeking therapy and parenting support to address emotional regulation and behavioral concerns. Engagement and assessment. So, the engagement process was from the very first session within the first 10 minutes. It included the mother to come into the session to build comfort and trust. In the corner of this slide is the book Somebody to Talk to, and this really helps at a developmentally appropriate age to explain therapy and what is confidentiality. So, reading this book, the mother was included in the session, and then after reading the book, it was explained to my client that after reading the book, the mother would exit the room and go wait in the waiting room until we were all done. This was to build rapport. And we also did that through drawing, play, and conversation in that first initial session. And all across the board, used developmentally appropriate motivational interviewing techniques. Some barriers that I faced was this is a young age limit, and it's difficult at this age for some individuals to have more insight and or be able to pay attention to books or the activity that we are going to do. Or even when we are doing play, it's still, are they able to role play with me? Are they able to showcase some, certain assessments that I'm looking for, as in, are they able to transition from playing with one toy to now we're going to transition to this next toy? Are they able to share? So those are always some barriers going into the session that could happen. Of course, we always hope that they're able to process all of this as we're going through each session. Some of the assessment tools I used was a biopsychosocial assessment, which was completed with the parents before I met with the client. The strengths and difficulties questionnaire was completed by the caregiver to assess emotional and behavioral functioning. We also did the play-based and the observational assessment to evaluate emotional expression, attachment, and developmental functioning. And then always at the beginning of each session, I would ask the parents, how have things been, and really utilize that parent report. Risk and safety, no current indication of suicidal ideation or self-harm. The primary safety concerns included the physical aggression towards the caregiver, but if it would escalate, there was a safety concern with the client potentially hurting herself. In the sense of hitting someone, throwing herself around the room, was the room in an environment where she could display that emotions appropriately and in a safe way? 9 out of 10 times, no. There's going to be a coffee table in the way, or there's going to be a wall that she's going to fling herself off the couch and potentially hit her head on the wall. So that was a concern. Focus on ensuring safety during dysregulation episodes and supporting parental response strategies. Then when we get into the intervention and planning, so I'm going to list the 3 theoretical frameworks and modalities that I have utilized with this client in our sessions. So a first was attachment theory, which explains how relationships with caregivers shape emotional regulation, safety, and stress response. So first, the assessment. So it is helping to interpret intense escalation towards the mother as attachment-based distress rather than purely behavioral. It's understanding that these behaviors may reflect fear of separation or need for co-regulation and emotional insecurity after these transitions. And then we have the intervention. So this is guiding focus on strengthening caregiver and child attunement, co-regulation strategies, and constant caregiver responses. We then also have the child-centered play therapy. So this is a therapeutic approach where children express emotions and experiences through play rather than verbal processing. So in the assessment, this is where the client's play reveals emotional themes such as family dynamics, attachment needs, and regulation capacity. The intervention is going to provide a structured yet child-led space to process emotions safely and build coping skills. So as I said before, this is some role playing, maybe with some stuffed animals. So I am working with the child where I, as the role player, is maybe telling the child no and then seeing how they respond back to me. Or it's playing with the dollhouse. Who is the father? Is the father involved? Is the mother involved? Is there a child involved? So I am definitely not licensed in play therapy, but you can still use some of those approaches and themes to kind of understand just how they show up in their environment. Then there's also the behavioral theory and the CBT informed, this is focusing on how behaviors are learned and maintained through the environment, reinforcement, and consequences. So when we discuss assessment, this is identifying triggers and patterns. When we are understanding this, behaviors are viewed as learned responses to emotional distress and environment. And then we have the intervention, which guides use of consistent caregiver responses, positive reinforcement, and teaching those coping skills. As well with the intervention and planning, we have, culturally responsive and trauma-informed practice. We, as in me, treatment is considered the impact of the family's recent relocation from Colorado to Florida, including disruptions of routines and loss of familiar support. A trauma-informed approach was used by validating the child's emotional responses to change and focusing on safety, predictability, emotional regulation through developmentally appropriate play-based interventions. The client participation in these goals. So treatment goals were developed with the parents based on the child's presenting behavioral concerns, with a focus on emotional regulation, safe expression of emotions, and reducing intensity of dysregulated episodes. The child participated in goal-related work through play-based choices, structured activities, and engagement during session that supported skill building in a developmentally appropriate way. The ethical issues and dilemmas. So, ethical considerations included balancing the caregiver involvement with maintaining appropriate confidentiality and therapeutic boundaries in early childhood treatment. Also, some considerations included providing developmentally appropriate explanations of therapy concepts and ensuring informed consent through caregivers while still respecting the child's emotional experience. So, that is always an ethical, issue when dealing with children and family. At this stage, she's 4 years old. I am able to discuss a little bit more of what that client is saying with her parents. If she's using language as "I hate my mom," of course, I am not going to tell her mom that in those specific words. But I will, maybe validate mom's concerns when she would bring to me like we are not connecting the right way. And maybe I would back up mom and validate her feelings and maybe just do a little bit of reflection and, bring some things that have been said from our session to our parenting session, such as, yes, my client really is saying that, she doesn't like to be told no. Mom, I'm understanding that you are, the main person in your relationship with your child who is kind of implementing those rules. So I can really understand how, having to tell her no, having to do boundaries can be difficult for both you and her. Let's bring dad into the mix. So that's kind of where ethical issues is always difficult for me when kind of deciding what to tell the parents. But at 4, I am able to, she's only 4 years old, so I'm able to tell the parents a little bit more. And then when we're discussing, collaboration occurred primarily with my clinical supervisor, and it is an agency-based parenting support services, which ensures, consistency between child sessions and caregiver strategies. So when we're doing those parenting sessions, that is where we align both the home interventions and therapeutic goals. We're also improving consistency in responses to dysregulated behaviors, which is a challenge involved ensuring unifying caregiver responses during high intensity episodes. But there's also a positive, which is the outcome was improved with the parenting understanding and engagement in the intervention strategies. So the evaluation and termination. The treatment outcomes were measured primarily through a qualitative parent report and observed behavioral change over time. Parents reported a significant reduction in frequency and duration of dysregulated episodes, decreasing from approximately 4 times per week, lasting an hour to an hour and a half, to about once per week, lasting around 15 minutes. The client has also begun using coping skills toolbox, which we made within a session. That's, where you learn to hug yourself, to talk to your mom about your emotions, which she learned during our sessions, more about emotions. That's where you're doing the, breathing techniques such as bubble breathing or pinwheel breathing. In that box, we also made, kind of a stress ball with Play-Doh and balloons. That's where, she's feeling really angry, that she uses that ball to kind of, maybe take her anger out on instead of her mother. So when they were also using those coping school box during moments of distress, which indicated emerging skills, and really connecting and generalization across the board with our sessions. Weekly supervision with a qualified clinical supervisor was used to review progress, receive guidance, and adjust intervention strategies as needed. Supervision supported clinical decision-making and ensured appropriate intervention planning throughout treatment. Parents consistently provided feedback, positive feedback, and expressed satisfaction with the child's improvement and overall progress. They also expressed interest in transitioning to biweekly services, including a potential shift toward primarily parent-focused sessions due to the client already showing improvement. The termination is actually being handled as a transfer of care due to my graduation and my internship completion. So the progress includes preparing the family through advance notice across 3 sessions, providing space to process emotion with the client, and ensuring that the continuation of care through coordination with the incoming LCSW, making sure that she's up to date and is able to access my notes and understand and have any other questions. A formal handoff includes updated clinical documentation, communication with the new provider, and a transition summary shared with both the supervisor and family. So, when we're discussing the 9 competencies for social workers, number 1 is I maintain confidentiality, boundaries, and ethical practice throughout all of our sessions and treatment. Number 2, I supported the child's right to safety, expression, and access to services. Competency 3, I use culturally and developmentally responsive approaches that considered family context and transition. Competency 4, I applied evidence-based parenting education approaches from 40 Carrots to guide caregiver strategies and behavioral interventions. Competency 5, I followed agency protocols for documentation, supervision, and transfer of care. Competency 6, I built rapport with the child through play and engaged caregivers in treatment. Competency 7, I use biopsychosocial assessment, the STQ data, and observation to guide my own understanding. Competency 8, I use play-based and behavioral strategies and supported caregiver implementation. And then competency 9, I monitored progress through parent report, supervision, and behavioral change. So this was my second time working with a 4-year-old, and it is noticeably has increased my confidence in engaging both the young child and their caregiver in a clinical setting. It also helped me, to see more clearly how differently children can present developmentally, even when they are the same age, which made me more intentional in how I pace sessions and chose interventions. I genuinely enjoyed working with this family, especially how engaged and open they were to feedback. It was meaningful to see them actually, use the strategies that I was doing in the sessions. They're also doing it at home, like the coping skills box. And, they reported real behavioral change. So that was, really good for me to see while I had this client and before I, transitioned that care. There were moments where I felt, the client might benefit from more of a structured emotional regulation work during sessions, like more direct coping skill teaching in the moment of escalation. But I stayed aligned with the treatment plan that the parents and I put together, and I also focused on emotional regulation. I did focus on coping skills and that caregiver implementation rather than shifting based on my own clinical impulse. So, that helped me practice trusting the treatment process and staying consistent with my goals instead of maybe rushing through it. This case shaped my professional identity by reinforcing the importance of collaboration with caregivers and staying developmentally appropriate in early childhood work. Moving forward, I want to continue building confidence in managing severe emotional dysregulation in young children and strengthen my use of caregiver-led interventions. For my self-care, I use supervision constantly. I process difficult sessions afterward instead of carrying them with me. And I made a point to mentally close out work after each day so I would stay grounded outside of my internship. Thank you all for listening to my final case presentation, and I hope this gave some insight to if anyone ever has a 4-year-old client. Thank you.